Good evening, everybody. And I'm going to discuss here about the OCT-guided PCI step-by-step and imaging to think beyond imagination. So conventionally, we have been doing angioplasty by using a coronary angiography, which is used to evaluate the coronary anatomy and as a guidance to the PCI. But coronary angiography guided PCI has its own limitations, particularly because it's a 2D luminogram. We can see only the shadow of the lesion. We cannot depict the details of the arterial wall or its dimensions, and we cannot characterize the plaque. There are a lot of subjectivity in the lesion assessment, and there are limitations to assess the result of the stent implantation, particularly in terms of the expansion and apposition, edge dissection, and tissue prolapse. Here is one example where there are discrepancies between the angiography and imaging, where if you see here in the LAD, in the LO cranial view, a mild stenosis of LAD, which actually on imaging shows focal lotus root-like lesion consisting of multiple cavities with septations. So it's time for a high-resolution imaging where we need to focus something beyond angiography by use of intravascular ultrasound and OCT. And this actually helps to minimize the MACE not only major adverse event, but mistakes using the coronary angiography coronary evaluation. So most of the integrated modern cath lab have the imaging integrated with the cath lab, which helps us for a higher resolution, low radiation images to assess the physiology of the lesion. And most importantly, these are co-registered with the angiographic view so that we can have a precision in our therapy. So let me take you a step-by-step approach to the imaging. And this is a 54-year-old gentleman with an exertional angina for 3 months and now having episodes of rest angina for the last 1 month. He's already on a DAPT statins and low molecular weight heparin. ECG showed ST changes, echo was normal, troponins negative. He's a non-diabetic and normotensive. So classically in the both cranial and cordial views, which I have shown here, it shows the tight bifurcation lesion 111 involving both the diagonal and the distal LAD. And if you look at the size of the diagonal is very comparable to that of the main vessel, that is the LAD. So how to approach this case with an imaging? And the image-guided PCI workflow goes like this, that each imaging run serves as a separate purpose. Pre-PCI, that is before we decide for how to approach, this actually helps to decide the strategy. And after the stenting is done, the imaging allows us for the optimization of the stent as needed. So this is the algorithm that goes by. In the pre-PCI, we look at the morphology, length, and diameter, and this is abbreviated as MLD. And post-PCI, to optimize the lesion, we look at the medial dissection, apposition, and expansion, which is abbreviated as MLD, the max. So the algorithm is the MLD max approach. So what does the pre-procedure assessment tell us? So pre-procedure, we look at the morphology, length, and the diameter. The morphology is basically to identify the morphology of the lesion in the disease segment, and particularly focusing on areas of high calcium. So why detection of the calcium matters to us? The calcific lesions, which has a calcium arc of more than 180 degree, more than 0.5 millimeter thick, or more than 5 millimeter length, are at risk for stent under expansion. And under expansion is the crux for the device failure. So we also decide for a morphology guided PCI based on the morphological evaluation of the lesion. Here is an example of the morphology. If you can look at here, this is a normal looking vessel. We have a fibrofatty plaque here, a lipid plaque, beautifully exemplified the calcified plaque here, which is of one single quadrant. Also, we can look at the intraluminal pathologies like here. This is a red thrombus and the white thrombus occupying the lesion. When it comes to acute coronary syndrome, we can differentiate whether it is a plaque erosion or an intimal tear, a plaque rupture out here, or a calcific nodule. And accordingly, we can decide our strategy. It's very important to look at the culprit lesion because many times the culprit lesion may not be same as the stenotic lesion. And this is depicted in this cartoon where we can actually miss the culprit vessel if we are not very careful and if we don't resort to imaging in particularly suspicious cases or in ambiguous cases. The second step is the determining the length. And for measuring the length, we actually select the landing zones, that is the healthy tissues, where we can visualize the EL. Should the EL, that is external elastic lamina, which represents the healthy tissue, is not visible, then we can look at the lumen diameter, where it is least diseased. There are no TECFAs or lipid pools. Why does the length matter? The stent should be completely covering the lesion and avoid the stent edges to be landing in the high risk zone, and therefore we need to measure the length. Now here is an example here. So we measured the distal reference where we can see all the three layers carefully. And again, the proximal, we measured the distance between the two, and this is the length. And we can also reconstruct the same in the OCT 3-dimensional luminogram to visualize the picture and assess the length. The third step is measuring the diameter. Again, we need to identify the proximal and distal landing zone. And the diameter here, both in the proximal and distal, helps us to choose the balloon diameters, which are typically, with reference to the distal diameter of 0.9 to 1 ratio. But if the lesion is long, sometimes we need another proximal balloon sizing, which is according to the proximal reference. We choose the stent according to the distal reference, and for proximal pod that is proximal obturation, proximal reference vessel are used. Here is an example of how do we choose the size. This is a really healthy segment. You can look at the EL. So we take the EL measurements in orthogonal projections, and we actually take a stent which is quarter size down to this diameter. If the EL is not visible, we actually look the lumen dimension in relatively healthy segments, and then we upsize the stent by a quarter. So this is what the pre-procedure is. We try to identify the proximal and the distal referenced vessels. We look at the morphology of the lesions. We look at the stent, intended stent length. And if also we look for any side branches if there, and look at the pot length in case of bifurcation, which should be at least the size of the smallest length balloon, which is on the shelf. Sometimes we go for a lesion-specific additional assessment. Like, for example, if you have a bifurcation lesion, we look at the main branch, the lesion morphology, and any calcium at the site of the bifurcation. We look at the side branch, the disease involvement. And most importantly, we look at the branching point angle and also the carina tip angle and the length, that is a BP branching point to the carina tip length. And what is its importance? The carina tip angle, if it is less than 50 degree, or a branching point to carina tip length, if it is less than 1.7 millimeter, these are the independent predictors of the side branch occlusion. And therefore, we need to evolve a strategy where we can protect the side branch. If there is a calcium on the contralateral wall of the origin of the branch, again, there are chances of side branch occlusion by carina shift. In calcified lesion, we look at the calcium, about the distribution of calcium arc. It is one quadrant or it is complete as in this, whether it is superficial or it is deep, or there is a calcific nodule, because accordingly, we assess and devise our strategy. Now, this is the rule of 5%, where if you have a calcium which is more than 0.5 thick, it is occupying more than 50% of the vessel size area and more than 5 millimeter long. These are the factors where there are chances of stent under expansion, and therefore we need to treat them accordingly. Angiographic co-registration is also a must if you have this facility, and most of the modern machines do have this, where as the cursor moves, I can see here the cursor moving, we can correlate with the longitudinal section and the cross section, and we can precisely pinpoint our stent positioning and work accordingly. So how do we apply this information from the pre-PCI vessel assessment? we actually can go for a morphology guided lesion preparations. For example, if we have a lipid-rich plug, we can go for a direct stenting. If we have a fibrotic, we can go for a compliant balloon. If we have a mild to moderate calcium, which is less than 2 quadrants, we can go for a non-compliant balloon or maybe a cutting balloon or a scoring balloon. And if we have a severe calcium, we need an atherectomy or an IVL device as shown in this algorithm. In case of in-stent restenosis, again, we can classify the in-stent restenosis into 5 types, and we can choose our strategy depending on whether it is new intimal hyperplasia, whether it is new atherosclerosis, or whether there are calcium in it. So coming back to this case, now here I dilated because it was a very tight lesion. So I dilated with a semi-compliant balloon, both in the LAD, and you can look here, the OCT run. It's a very tight lesion. It's a fibrotic. This is the dissection flap out here. And then a lipid-rich segment out here. So precisely, I can go for the reference vessel diameter in the distal and the proximal part. We can measure the length. And I can decide on the strategy how to prepare this lesion, this is be very amenable to a semi-compliant balloon dilatation. Also, because this is a bifurcation, I interrogated the side branch, which was again very tightly diseased. It's a very significantly sized vessel. So I decided to go for a 2-stent strategy as shown in this. So diagonal with a 2.25 into 18 millimeter. And then this is a DK crush technique. I crushed the stent with a 3 into 15 balloon. And this is the crush. Recross the side branch. And if you look at here, the wire, it is crossing somewhere in the middle part of the stent. And then thereafter do a kissing balloon dilatation. And this is positioning of the main branch vessel. And this is a pot with a 3.5 into 12, recrossing the wire mostly through the distal half now. And then a kissing balloon. This is the second kiss dilatation, followed by a repot. So sometimes we adopt to an intra procedure or the OCT, and here intra procedure OCT basically to assess, for example, if we are using a plaque modification device, like here, a cutting balloon has been used, an angiosculpt, and rotational atherectomy and lithotripsy to see whether we have cracked the lesion and cracked the calcium, because calcium fracture is always related to, reflects on the outcomes that we achieve. Another important thing that we assess during the procedure is the wire cross. So most of the bifurcation lesions, we need to have a distal cross, except for the DK crush, as in this case, this was a proximal cross. And also, if by accidentally we have made an abdominal cross, we can avoid a catastrophic outcome by dilating in the abdominal passage. So we can always look at where we have crossed. After we have deployed the stent, we go for a post-procedure assessment. Post-procedure basically to see at the dissection, apposition, and expansion, which is abbreviated as MAX. Dissection, we actually try to identify the edge dissection and address if it is significant. The criteria for the significant dissection is if the dissection has penetrated the middle layer or is greater than 1 quadrant. You can see here, this is the intimal dissection, and here the dissection has penetrated deep into the media, and it is about 1 quadrant, and this is an advantageous dissection. So this is another case which I had done, and here you can see here the dissections has been not only intimal, it has also resulted in intramural hematoma, so it needs to be addressed in this case. Apposition, basically how if there is a gap between the vessel wall and the stent, and we identify the malapposition and address it if it is significant. The criteria for the significant malapposition is if the gap is more than 0.3 millimeter or longer than 3 millimeter. And the last thing is the stent expansion. So stent expansion means we should be able to expand the stent with reference to the reference area. That is, it should be at least, the stent area should be at least 90%, and more than 80% is anyway acceptable. So here is, like, for example, in current generation OCT machine, this is the apposition indicator in white. Wherever you have red means it is malapposed. And also you get an idea about from the lumen profile about the stent expansion. Like in here, it is 96 expanded distally and 85% proximally, which is very acceptable. And here you can also look at the carina at this side, how it is expanded. So this is again an example where you can see here my stent has landed in a zone where it has caused dissection at the edge. And this whole red line marker is basically a malapposed segment. So needed another stent and further optimization of the vessel. So many times there is a confusion amongst the operators about malapposition and under expansion, both of which can occur independently as well as can coexist. Malapposition, acute malapposition is that there's a gap between the stent and the vessel wall. And this is very common either in the proximal edges or at the sites where there are eccentric calcium. Here, if we can look at here, the stent expansion is quite adequate at a 6 millimeter, which is quite, proportionate to that of the proximal and the distal reference area. But the stent is malapposed. Stent expansion is where the stent has not opened up to at least 90% or more than 80%, I would say, to the reference segment. For example, here, the stent looks opposed, but if you look at the stent area, it's only 3.1, while the proximal and the distal reference are 6 millimeter square. So why stent expansion matters? Because under expansion leads to stent thrombosis, in-stent restenosis, and other adverse cardiovascular events like the target lesion failure. In other words, it's a device failure. Another important thing that we need to look at is the side branch access in case of bifurcation. If you look at here, there was the ostia of the side branch was not visible angiographically, and this is an OCT picture. And this is how it looks like after a kissing balloon dilatation. Also, the OCT run in the main branch can help us to visualize the side branch, how it looks like in many of the cases. So post-procedure, to summarize here, we can look at the stent length, look at the lumen profile, the stent edges, whether there are dissections or not, and how the stent is opposed and stent is expanded. So coming back to this case, this was how the stent had opened up here. You can look at the stent expansion being good. The edges are quite okay. There is no dissection in this, as we can see here. And stent very well expanded.
Dr. Roy, kindly conclude your talk.
Yeah, this is pulled back from the main vessel, and this is pulled back from the side branch, and it looks perfect. These are the still images. Carina is very well built, and this is how the angiography looks like. So the summary of the steps, the MLD max, we look at the morphology, diameter, and the proximal and the distal reference diameter. We look at the length, and we look at the edge dissections, the expansion, and the appositions. So I'll just skip this because the evidence will be there. To conclude, angiography is still used as a gold standard. Imaging has overcome many of the limitations of angiographic guided PCI. It has been commonly used in complex lesions and has become an essential tool. IVUS-derived, the MSA is known to be a long-term predictor of MACE. Yet, again, according to AH and ACC, use of IVUS remains a class 2A indication. OCT has a shorter history than IVUS, but has a better resolution and user interface, providing more information on stent optimization. So if we have this technology, there should not be any excuses of not using it if we want a precision in the PCI result. Thank you.
Thank you, Dr. Sanjeeb Roy, for the very informative talk. And we'll have a discussion at the end of the session.